Hi, everyone. Welcome to our session on diabetes prevention and management. I'm Aaron Cahall. I'm the communications manager at Chase Brexton Healthcare. With me today are Dr. Nowreen Haq, who is an endocrinologist, Nicole Stein, who is a registered dietitian, and Dustin Dang, who is our clinical pharmacist. We're going to talk a little bit about diabetes, what it is, ways to prevent the development of it, and ways to manage it and live a healthier life. And also talk a little bit about Chase Brexton's new program, which integrates a lot of the services that we've already offered to help patients with diabetes manage their diabetes and get more integrated, more effective care. So for the group, I guess I'll start with a simple question. What is diabetes?
Great. I think there is a very, very short answer and very, very long answer to this. Very short answer is anyone who would have a blood glucose constantly in the blood level more than the expected range would be called an over diabetes. Now, there are many, many ways that we are now classifying diabetes. Are you pre-diabetic, meaning is your blood glucose a little bit high than normal, but not to so high to call it an overt diabetes? And there are many ways to diagnose how you're a diabetic individual. So there are there is clinical symptom, and there is also a lab value attached to it. So to give you a very short definition of diabetes is when you persistently your blood glucose level fasting is more than 126 at all times, and we are talking about two different assessment of blood glucose levels in two different times, not just one but twice fasting level. That can qualify for diabetes. What can qualify for pre-diabetes is if your blood glucose level is more than 100 but less than 126 fasting on two different occasions, or your A1C, which is a aggregated blood glucose level over 2 months of time. Your hemoglobin levels are actually binding the glucose particles, extra glucose particles, and that is an aggregate average of blood glucose over 2 months. If it's less than 5.7, you're okay. 5.7 to 6.5, you're pre-diabetic, meaning we are going to watch for for every precaution to take, and that's where Nicole's role comes in. That's where Dustin's role comes in, and my role comes in to help prevent the over diabetes to happen. And then over diabetes is if your HbA1c is more than 6.5, again on two different values. So we are always cross-checking, and making sure that the precision is there to to diagnose. Symptom-wise, of course, you will have a lot of telltale symptoms. Frequently getting up in the to urinate, because your glucose load is high in your blood. Frequently getting thirsty. Frequently getting very hungry at night, or having late night cravings. Having obesity that you are actually it's difficult to control, and particularly the abdominal obesity, which has been really the talk of the nation and perhaps on the world because of the COVID pandemic, what we have seen in abdominal obesity, diabetes, and COVID interrelation over the last year. So I gave you a long answer to a very short question, and I hope I'm not taking anybody else's time.
Real quick, I want to introduce Dr. Sarah Connor from our Columbia Center, who's just joined us. She's part of the diabetes management program as well. Dr. Connor, hi, good to see you. Thanks for joining us.
Hi, everyone. Sorry, I'm a little bit late.
That's all right. I was just asking the group a little bit, some of the basics of what is diabetes, and even maybe even more simply, what is blood sugar? What causes it to increase, decrease? When we tell a patient, their blood sugar levels may be high or low, what does that mean, and what can they do to affect those levels?
Okay, I missed Dr. Haq's explanation. Did she already answer that question, or do you want me to?
No, I think she just went over essentially, the diagnosis, how to get diagnosed with diabetes, and essentially what the basics about that is, but not about blood sugar.
Okay, so blood sugar. So I guess if she went into what the exact levels, but a lot of people when they come in and they say, I have sugar, and yes, we all have, you know, high glucose levels, but I mean, not high glucose, we all have sugar in our body, but the concern is when it gets to a level where it's not responding to our insulin. And then we have an excess of glucose, and when we check it, it can be very elevated. I wanted to go in, there was, I wrote down some notes, just to, you know, kind of the basics of diabetes, the ABCs, about the A being the A1C, which is tells us what your sugar is over an average of 3 months. A lot of my patients come in and think that, no, we can't check that because I just ate. And I said, actually, it's one of the most helpful tests, because it doesn't matter what you ate today. I'll find out what you've been eating for the past 3 months. So that A1C test is helpful for that. And that's actually what we use as a goal in terms of managing diabetes, a certain level that we want it at. And we can also tell if someone has pre-diabetes, you know, as a warning that, you know, diabetes might be in the future. And then the B for blood pressure, which is also a big component of this. You know, yes, we focus on the sugars, but like I said, there's a lot of other complications that can happen from diabetes. And one of them, you know, with the high blood pressure is leading, you know, to vascular disease. So we are concerned about that. And C, cholesterol levels. One of the newer things, I want to know how new it is, but one of the guidelines is almost anyone with diabetes should actually be on this statin medication. So some people come in and your cholesterol levels may actually look okay. We are specifically concerned about the LDL, which is the bad cholesterol. And depending on that level, sometimes we determine the dose of a statin, but actually, in order to decrease risk of, you know, cardiovascular, you know, disease, stroke, heart attacks, anyone with diabetes should be on a statin. And I don't know how new of a recommendation that is. I don't know what year it is, especially back in my training, like 15 years ago, it's not something that we did, but that's also something. But if you come to the Chase Brexton Diabetes Program, we sort that all out for you. It's not something that patients have to memorize or know. We will get you all set up with that.
So let me ask this, maybe for Dustin or Nicole, how common is diabetes? You know, it's a word people know. Certainly some television shows will wield as a scary thing. You could be headed for diabetes or something like that. But how common is it among the population generally?
That's a good question. I feel that an important thing to distinguish is that, you know, when we talk about diabetes, that's actually a pretty big umbrella term for different types of diabetes. And primarily the types of diabetes that we, you know, track the most is probably the type 2 diabetes, which is the most prevalent in the United States. And there's type 1 diabetes, which is a little bit less prevalent. And so we're talking about type 2 diabetes. You know, I believe, you know, about 1 in 10 Americans have a diagnosis of type 2 diabetes. So we're talking, you know, 30+ million Americans suffering from this disease. And we're talking about type 1 diabetes. It's definitely a lot less prevalent. I think the last time I checked, it was something like 1.6 million. 1.6 million Americans have type 1 diabetes. And so that's kind of like the numbers that we're seeing now as far as pre-diabetes, gestational diabetes, and all the other types of diabetes. You know, there's a much smaller population, but it is extremely prevalent here in the United States.
Yeah, and I think, you know, we're seeing a lot more cases of diabetes. You know, part of it is probably due to genetics, you know, family members and parents, and, you know, going further out. And another part is just lifestyle behaviors, you know, whether there is overweight or, you know, too much abdominal fat on the body, whether it's, you know, the diet is really limited in certain nutrients and excessive in other nutrients like carbohydrates or lack of movement. So, you know, it's growing because, especially during now with COVID, we're a lot more sedentary, and our access to food and, you know, all the things we need may be a little bit more limited. So all of those can impact the prevalence of diabetes.
So let's talk about those.
One second. to what Dr. Connor had very nicely like summarized ABC of diabetes. Let me tell you what the slogan is now. It's the ABCO of diabetes.
Oh, thank you for
Yes,
that.
also. And really the O is for obesity. So coming back and circling back to what Dustin said and what Nicole said today, obesity, as you know, have been like rampant and kind of had been an eye opener over the last 1 year, because clearly we have seen the metabolically healthy population and metabolically unhealthy population, and had been like, more emphasizing on prediabetes than ever before, because we have seen how immunocompromised state can actually affect the COVID, and how obesity has literally shown a very strong correlation with morbidity and mortality in COVID-19 pandemic. So having said that, I think we have been kind of looking at all our pre-diabetic obese population and trying to start treatment, which was just diet and and exercise before had been a little bit more robust control with some medications like metformin or GLP-1 analogs, and we can talk a little bit about that as
let's do that. We'll start. There's two elements to this, right? Prevention and management. If someone does that, so let's start with prevention. If somebody is pre-diabetic or even just has risk factor, significant risk factors, either genetic or lifestyle based, how do you start helping that person avoid a full-on diagnosis of diabetes? What kinds of strategies do you employ?
So I can.
I was going to say diet, so hit it, Nicole.
Yeah. So starting with the lifestyle, and I think this is true for really anyone out there, regardless of, any medical concerns they're going through, or even lack of medical concerns, or whether they do have diabetes or not, is just, the diet aspect. And I say more like a lifestyle aspect. So, making sure that we're having a variety of foods, a variety of nutrients, making sure we're getting our fruits and getting our vegetables in every day, having the lean protein sources, more whole foods, less of the processed and added sugars, and getting those whole wheat, whole grain products. So really everyone out there, like to eat the rainbow, like to have variety, like to have different colors, not too much excessive intake on, carbohydrates or a certain food group. So that's going to be really beneficial. And I've seen a lot in our patients who have made those changes are seeing the difference, seeing improvements in their diabetes. Then there's also the movement aspect. So moving the body, exercise doesn't have to be going to the gym. It doesn't have to be running every day. It's just moving the body, whether it's taking a walk, doing some dancing, doing something fun, cleaning the house can be exercise, can be pretty strenuous. So making sure that we move our bodies, almost every day for at least 30 minutes. So, all those will help the body, in terms of the weight, get to its rightful place. I think the weight comes from the behavior aspect. So focusing on, better behaviors, throughout the day, every day.
I wanted to add, Nicole can give them, a very in-depth, evaluation of what their diet is and some, and changes. And I think it's very helpful too, because sometimes my patients will come in, they say, I don't know what I'm doing wrong. This is what I'm eating and things, but nothing's changing. My weight's not changing, my diabetes. And I said, well, a lot of times, you have this perception that we are eating healthy. Some people are. Now some people will come in and say, hey, I know what I need to do. I'm not just not doing it. And then we'll work on that. The other thing I wanted to highlight, because sometimes, I just kind of, let's just focus on one thing of, what beverages, sugary sweetened beverages, cut that out. And I'm family medicine, so I see kids too. And that's one of the things that, we emphasize very early on. And then try to, eliminate snacking, try to stick to, your 3 meals. And then the same thing about movement. Like you said, it doesn't have to be, let me go find a gym membership. I have to get into a class. It's just any movement, start with small goals.
Yeah, and I like to kind of build on that point, and to clarify for the audience, when we're talking about preventing diabetes, it's mostly, again, talking about type 2 diabetes, whereas type 1 diabetes is more of a less of a lifestyle disease and more of a genetics kind of disease. So when we're talking about preventing type 2 diabetes, I agree with everything that's been said thus far, but I like to kind of bring it back to the patient and really focusing on mindfulness. Just knowing where you're at and where you need to go is a big one. Just like Dr. Connor was saying, patients may think that they're eating healthy or getting enough movement, but I think that unless you really get down to it and maybe physically write it down, I eat this much per day, I walk this much per week. I think that's really the first thing that patients need to do is just find out what their starting point, and then setting a goal that they can attain that's reasonable, but also challenging and worthwhile at the same time.
Something I've always wondered is how connected is the idea of weight loss specifically to preventing diabetes? Because I have the sense that folks sometimes think that losing weight, certainly losing weight it seems like would be part of it, but that there are other factors involved that could, to your point of cutting out some of the less the most unhealthy stuff. Are those two ideas necessarily connected, or are there, could someone maybe not see so much difference on the scale, but still be doing things to help prevent a diabetes diagnosis?
I think I can take that question. So basically what you're asking is that, to change or to understand the thought of how weight, if you're not losing weight and getting the frustration like Dr. Connor was saying about the patients are coming in and saying that, what can I do? I am not losing weight. So the question is that, are you gaining weight? So the big question would be that, are you having a stable weight versus are you gaining weight or are you losing weight, right? So if you are having a metabolically healthy habit, chances are that you will not push your blood glucose level to the point that you're starting to have the insulin resistance. Why do I say insulin resistance? Because type 2 diabetes is not about insulin at all. There is plenty and abundant insulin in your body in type 2 diabetes. The problem is because of the obesity, the insulin is not getting the receptors, or there is no sensitivity for the insulins to work in the body tissue. And that's how you're getting the diabetes. So if you are not seeing the weight loss right away, it is because your metabolism is probably very slower than other individuals. And that's how you're getting pre-diabetic in the first place. You're not probably not in that curve of very active metabolizer. And that's the norm. That's where the FTO gene or the obesity gene comes into play. And there might be a familial component of the metabolic syndrome. But what we can change is the diet habit and the behavior and the progression from pre-diabetes to diabetes. And that's where I think we have to really make sure that patients are on the same page with us and understand how it might be frustrating not to see the weighing scale immediately dropping down and giving you the gratification, but the gratification will actually come from going from pre-diabetes to over-diabetes, and we can prevent that. Science has told us, and then we have evidence that we can prevent pre-diabetes to over-diabetes just from behavioral change. I wanted to also emphasize on another important thing about the glucose monitoring and the behavior, how in science now it has changed, and given us an excellent diabetes control. So when we were looking into HbA1c, chances are that, you're half of the time high and half of the time low, and then your average HbA1c can be a perfect 7.5. Now is the era where we are also having technology to advance, technological advancement to show the time in range blood glucose level, or a 24/7 log of your blood glucose level to give you an exact idea of what is happening when you're eating a piece of donut, or when you're fasting and you're waking up in the morning, and how soon is your blood glucose level going up and how soon is it coming down. So it's giving each individual a body map or a trend. So that I think has been really a very, very great, modifier for diabetes prevention and also diabetes management.
Yeah, and I kind of want to help illustrate this point. So if we want to put numbers to this, especially when it comes to testing your blood sugars, the A1C is a vital part and a piece of information to help manage diabetes, but probably the most important is when patients themselves are testing your sugars at home. So when we talk about the average blood sugar being measured via the A1C, that's all it is an average. So depending on what that looks like on a day-to-day basis will tell us, what your real control of your diabetes is like. So for example, you have two people, Bob, if they're following, their exercise plans, their diet, making healthy diet choices, and taking their medications as instructed. If they're taking their blood sugars regularly throughout the day, let's say their lowest blood sugar in the morning is like 130, and after 1 or 2 hours after a start of a meal, it's 180. If we take the average of that, that's give or take 150, which is about a 7% A1C. Now, if you reverse this, let's say you have someone who's not going through some circumstances, let's say Jimbo. They take their blood sugar, maybe their lowest blood sugar of the day is 50, because they're not eating, they're maybe taking their medications incorrectly. And then at their highest sugars of the day is 250, And so if you take that average, that's still 150. The A1C is still going to be, 7%. But you can tell by, patients testing themselves that, Bob has much better control of their diabetes versus, Jimbo, who could use some help. And now this is obviously a very simplistic representation of that, but I hope that kind of illustrates the point on why it's important for people to be testing their sugars on their own at home, so they know exactly on a day-to-day basis what they do and what they eat, how that affects their diabetes control.
If somebody, let's move on to the management part. If somebody comes in, they are already diabetic, perhaps when they come to us, or this does develop into a diagnosis of type 2, most likely diabetes. What strategies do you employ? And again, working together under the program that we've started to establish to help them both manage some of the symptoms and to try and get it under control, and essentially what hope can we provide to them to get their diabetes under control and help them be healthier?
Well, I can say, because usually I think sometimes I'm might be first line in seeing these patients. So if someone is newly diagnosed, or they already have a known diagnosis, but it's not been well managed, and we have to look to see, well, let's just say newly diagnosed, just giving a kind of a basic introduction of what this means. A lot of education, a lot of support, because people are pretty scared when they find out and they say, what does this mean for me? And it means very different things for, depending on when we see it, when we diagnose it. If we caught it, early on, and that could be someone who came in who had symptoms, someone who was, really thirsty, urinating more, or it could be someone who didn't have symptoms but had risk factors. So we just found it on routine screening. And then going from there, so like I said, there's different levels of it. I always, explain to patients, there's some people that come in, and depending on what that level is, we might be able to manage it with just a pill, and doing, diet changes, which is the hugest, part of this. There's some people that it's a little bit more advanced, and we might need to go straight to insulin. I have some patients, I don't want to say argue, but kind of, they're not excited to go on medication, and I understand that. They hearing a diagnosis of diabetes means many things for most people. They're scared, and what we have to do is reassure them that there are great treatments for this. There's things that that we do as a team. I kind of just say, we're the coaches. You're in the game. We're going to do this all together. There's lots of pieces, to the puzzle here that we're going to do. And sometimes I tell people, your first job is just to show up. Keep coming to the appointments, even if you're not listening to what the advice, or they're taking the medications. Just keep coming, because we're going to figure out why you're not, what happened, what are the barriers, and we're going to work with through there. There's no judgment. There's this is not an easy task to take on to manage diabetes. And then go from there. And I also wanted to add about testing. Sometimes when I, mention to people, well, let's start testing their sugar. And, some people have already tried it and they have a lot of pain, or there's inconvenient, a couple different barriers. But now we actually, with the continuous glucose monitor, that's another option that we have, that we can actually get a lot of times before, many years ago, it was only approved going through hoops and, insurances to cover it. But so we have that as a new option too, which a lot of times we can't make further changes until we know what your sugars are. Like I said, that we were talking about that A1C test. Yes, that gives us valuable information, but a lot of times we need to know what's going on throughout the day. So that was my short version, but
I think the main point, Sarah, I really like how you mentioned, Dr. Connor, that we're here. We're here as a team. We're here to support the patients. It is really scary, what's going to happen, what if, what is the road looking like ahead of me. And the great thing about this diabetes management program is that, we're here as a team. We're all together. It's not like we send patients off their way and be like, see you later. We have follow-up visits, I know with Dr. Haq and Dustin and myself, pretty frequently, every few weeks, just for the accountability, for the support, to make sure that, the understanding's there and the best treatment is there. So, we're here for everyone.
Yeah, and I like to just throw out, when someone has diabetes, on our end, on the healthcare end, a lot of, things pop up. We need to get special testing, vaccinations, and all these things. And to let, to kind of lay it all out there and for the patients to kind of, digest and really understand that can take time, multiple visits for sure. And so, on the pharmacy end, that where I jump in is I essentially help smooth out the ruffles. I think on average, a person with diabetes, they have something like 300 more decisions they have to make per day, just to manage their diabetes. What to eat, when to take my medicines, when do I check, all these things, and medications, getting them covered, where do I get them, refills, all of those things are just more decisions that we try and help take off their plate if they really don't need to bother with that or to have headaches about it. So that's where I step in. I help to make sure that the patients are getting their medications. That there is no barrier for a patient to get their medications on time and in their hands when they need it. And also, medications themselves are a complicated thing. Sometimes you come in and you're only taking 3 medications, and you might feel like that's a lot, and sometimes it is for folks, but sometimes you also can come in and you have a whole list of medications, and not everyone knows exactly how they all play around in the body, and that's my job to help, see if what interactions might be significant, and if you're planning on changing or you have a question about something, then that's something that we can discuss for sure.
Well, I want to thank you. We're coming up on the end of our time here, but let everybody know that if you'd like to know more about diabetes, how to manage it, how to assess your own risk factors, including a very quick quiz that can give you just a very high-level idea of your potential risk, go to www.chasebrexton.org/diabetes-management, and there's all that information there, including some information about the program that we've started. We'll hopefully be expanding on diabetes management. I want to thank all of our panelists today. This will be archived on our Facebook page, and we'll also embed it onto that same webpage I just mentioned. So you can feel free to share it, let everybody know what we've covered here today. But thank you all very much, and we'll see you again soon.
Thank you.
Thank you.
Thank
Bye.
you. Bye-bye.
Thank you.